Dr. Professor Hassan, thank you very much for your invitation to this really nice online lecture series. I'm really honored to have the opportunity to give a talk on a field of the surgery for skull-base meningioma. So, which is one field with which I dealt many years when I was in Hanover under teaching of Professor Sami. So first I started my residency, as you told, in the Nordstadt Hospital, where Professor Sami was chairman, and then started neurosurgery there, and that's where I came in touch with these interesting tumors and also the excellent surgery, and so that was the beginning, and so that is will be the topic of my talk. Of course, the field is quite special but very large, and so it's not possible to present every section of the skull base or any type of skull base meningioma. So I would just limit on these where I did some clinical research and presented some papers about, but does not cover the whole skull base, of course. So the next, oh, doesn't. Okay, it doesn't move, or does it move? No, it does not move. Now it moves, right? Yeah. Okay. So as you all know, and you're very also experienced in this field, so so as you all know, the skull-base meningiomas present some of the most challenging pathologies encountered by neurosurgeons, and because of their depth of the tumor invasion, vascularity, texture, consistency, and also the difficult relationships to bony anatomy and cranial nerves, and also the blood vessels.
Professor Nakamura, sorry to interrupt you. You are in presenter mode, so we can see the sharing, and on the other side we also can see. Maybe that's the problem.
Oh, okay. So should I stop the presenter mode, maybe?
Yes, and just the slideshow. Yeah.
Just okay. Then just a moment. Okay. Is that better?
Yes.
Okay. So as you know, the skull-base meningiomas extend all over the skull base, and it is divided into several segments, which begin the anterior fossa, middle fossa, and the posterior fossa. And one can say that that you can remove most of the skull-base meningiomas, which are in the typical region with the quite fast-forward approach, standard approaches. So which includes the frontolateral or supraciliary approach, pteryno, subtemporal, or the retrosigmoid. And
Professor Nakamura, sorry, yes. Are you sharing your screen right now?
We are seeing only desktop, not the presentation, I'm afraid.
I cannot see anything.
Okay, just a moment. Oh, so.
Yes, now we can see the presentation.
All right, okay. Maybe the problem is that I've got two screens here. So, but it's not in presentation mode. It's a regular.
Yes.
Mode, right. Okay. Yeah. So with these standard approaches, most of.
I cannot see anything.
Oh,
No.
I can see the presentation, but it's not a slideshow. I can see all the slides. Yeah.
No, I cannot see anything.
No.
Can you see anything?
Yes, I am seeing, but not in full presentation.
Okay, now.
Maybe we can start again,
Full
stop
screen.
sharing and
It is
start
not
again.
on full screen. Not on full screen.
It's not on full screen. It's not in
Yes.
presentation mode. Yeah.
Yes.
Okay, but you can still not see the presentation, or
Yeah.
Yes,
We
we
see
can
the
see.
presentation, but not in full.
Yes, we can see the
screen.
preview and the slides on the right and the preview on the left. Yes.
yeah, okay. I can put on presentation, but I heard that there was some difficulty with the presentation mode. I can
Okay,
try
we
again
can
with
go like this.
presentation mode if you want.
So if you can do that, just the slideshow mode, we can try that.
Yeah, okay.
Yes. The second, yeah. Mhm.
So,
Yes. Yes, now we can see.
Okay.
you can see. All right. Okay. All right. So, yeah, let's just continue where so the standard approach. All you know the standard approaches, of course, and and then there are some where you need special approaches, and I think these are the minorities. You can almost cover really most of the meningiomas with these above mentioned surgical approaches. So, as we all know, rule of thumb was to minimize brain retraction, maximize bone resection exposure. However, the extensive exposure of the skull base itself can lead to some neurovascular damages, and also it is quite difficult to learn. Only experienced people can really use all the extended approaches, and as a rule, the more surgical exposure you do and perform, there are more possibilities for surgical complications and morbidities. So the aim of the surgery in skull-base meningiomas is radicality and a radical extension of the meningioma. But however, you're really you're trying to do it in a safe way, and the aim of surgery concerning radicality highly depends on some other clinical factors and also patient factors like the age of patient, general life expectancy, general condition, of course, location of the meningioma, anatomical relationships to neighboring structures, and also the invasive properties. Are there any extending preoperative cranial nerve deficits which are caused by the meningioma or not, which really leads your approach, and also the relevance of these deficits on the daily life and also the profession. So I think we can tell that every surgery in really complicated and large skull-base meningiomas is tailored and needs to be individualized to the patient itself. We've got many tools for that. Well, we've got of course the all the magnifying tools and navigation tools, and also the methods for 3D presentation of anatomical structures, and even displaying it in a mixed reality goggle, like you see in this video. We actually have in our institute the Brain Lab Mix Magic Leap goggle, where we can put the images 3D into the goggle and do the planning with assistants and other co-surgeons, and so which really needs. Which really helps to plan the surgery. And also the biggest thing is that you've got a really nice imagination of a tumor, like a tumor like this, which is on the screen. And I would just present this case, which was operated just a few years ago as an example where such kind of preparation for surgery can really help, or at least it helped me as a surgeon to do that. So there's just one case where as a 68-year-old woman, presented to our hospital. She was operated altogether 4 times. It was 2015, 16, and 18 in outside hospital in northern Germany. She already had radiation and also peptide radioreceptor therapy, was grade 2 meningiomas, and last surgery was in April 2021 in an outside hospital where they tried to approach this tumor from lateral suboccipital. So that was their choice of approach. However, they did not manage to resect the tumor or even reduce the volume at all because it was scarring and adhesive, and the texture was very, very hard, and due to many reasons. And then she presented to us with growing tumor, which was involving the cavernous sinus, the Meckel's cave, extending into the CPA. So important for us was that the patient was operated several times before, already had a right facial paresthesia and numbness, so trigeminal deficit. She had a complete oculomotor palsy with ptosis, so ophthalmoplegia, basically. Left hemiparesis and progressive ataxia. So she had some neurological problems which were progressing. She had already cranial nerve deficits, which made us the decision a little bit more easier because the tumor was invading the cavernous sinus, and it is very, very difficult to do cavernous sinus surgery in order to preserve cranial nerves, especially the oculomotor nerves, and so that made the decision a little bit more easier for us, and we were urged to do something for the patient because she was doing bad and she had progressive clinical deficits, and so that's why I made the surgery. So it was a surgery which was done. It's an anterior subtemporal approach where I made a transcavernous surgery, which I rarely really do or do not see the necessity to do that, because most of the patients present with intracranial nerves, but in this case, what's different? So we made a transcavernous surgery and then removed the tumor, temporal base and Meckel's cave, but we missed this part of the tumor because it was very, very far away from this approach, right at the dorsum of the midbrain, and it was so hard and almost calcifying that we really did not dare to resect it. And so that was the remnant. And finally, so we made a radical surgery in this case, but we do it really rarely in other cases. And only we can really proceed to this kind of surgery when patient has got significant deficits beforehand. And also, of course, when the consistency, texture, adherence to vital structures are okay, and that because these dictate the extent of the possible tumor resection intraoperatively. However, that's a finding that you only see during surgery. You cannot anticipate. So what does it mean? Minimally invasive skull-base surgery. It means basically that you try to reduce approach-related mobility and reduce cranial nerve and vascular mobility. And that is the trend of in our ages, because we've got many good options for remnant tumors. So you're not really in the need to do radical and high mobility surgery because it is allowed to leave some tumors in very, very deep positioned cases, and so you've got other options. So what are the tools for less invasive surgery via skull-base approach? We all use the microscope or nowadays the exoscope, and do additional endoscopic assisted surgery, or on the other way for anterior fossa and midline tumors, mostly the endonasal route would be one very good option. Just present a few series which I summarized and published during my time at Nordstadt Hospital in Professor Sami's institution. So I would just like to present a series as an example, a midline meningioma at the skull base, which is the tuberculum celli or planum sphenoidal meningioma. And so these are the meningiomas typically involving the anterior optic system, so both optic nerves, optic chiasm, the pituitary stalk to dorsal, and the carotid arteries just besides. And the aim of surgery is to resect tumors, but also stabilize or improve vision. So vision in terms of visual field deficit and also visual acuity. And I made an analysis of some of a series of these tumors which were quite differently operated during the ages. So at that time, beginning at the 80s, late 80s and early 90s, a lot of patients were operated via the bifrontal approach. So even for this type of tumor, and some were most were operated frontolateral or pteryginal, and so the main reason for bifrontal was, oh, you need a big opening, you've got multi-angle attack to the tumor, and finally one believed that this leads to a better result in terms of better vision after surgery. But however, it was not that case. Although the series is retrospective, we saw that that you can reach a really nice result with a quite less invasive supraciliary or frontolateral approach, and so even with a preservation rate of 92%, which includes preservation and stable postoperative vision. This is the view through a standard frontolateral approach from the right side. You see the tumor, right optic nerve, left optic is just hidden here, the left optic nerve, tuberculum celli. And then the optic canal, where of the contralateral side, where there are most often the tumor is hidden and involving the canalicular part. You can then look with the endoscope-assisted angled view into the optic canal, and it is especially helpful for the ipsilateral side because you cannot see it with 0 degree, and then remove the tumor. So that's the way we did a lot of cases and where we could reach complete removal. Now the other question is how to approach how to deal with the part in the optic canal. I will come back later to this topic. However, when it comes to visualization, the endoscope is quite useful because you can miss some tumor parts when you're not using angled vision and look into the optic canal. So especially for the ipsilateral side, where in our ciliars you could miss 30% of cases when you're not using the endoscope. Concerning visual improvement, the transcranial way is one route, but also there are many endoscopic surgeons who favor the transnasal transphenoidal route, and so even for tuberculum celli meningiomas. And so the main reason to favor the endoscopic route was that the visual improvement should be better. There are some reviews which showed that the visual improvement rate is better with endoscopic approach compared to the transcranial approach. Although my personal thinking is that these improvement rates are very low for the transcranial series. It's really low, so I cannot really believe that this is the truth. And also they say that they can nearly get a similar radicality, so concerning the gross total resection rate of the tumor. However, still the problem is, of course, the CSF leakage, which is basically not a problem when you go transcranially, and it's just still a main issue when you go transnasal, transphenoidal, and resect these tumors. So that's why, sorry. that's why we do not favor this approach for tuberculum cellae meningiomas or plano-sphenoidal meningiomas. Endoscopic assisted surgery is nothing new. So there are many experts in the past, and so just one expert, Axel Penietsky, who introduced this concept very early and did a lot of surgery with minimally invasive approaches, endoscopically assisted. So that is not a new issue. Now changing the topic, another field and area of skull base where we deal with meningiomas, for example, the medial sphenoid wing meningiomas, and and another group just beneath the clinoid meningiomas. I analyzed this series also in Hanover, and we analyzed how the patient do with the basic transcranial pterygium approach, and especially concerning the meningiomas which are involving the cavernous sinus or not involving the cavernous sinus. And we published this series, it's a long time ago, 18 years ago. We call it the medial sphenoid wing meningiomas. And so the distinction is sometimes very difficult. You need to see the attachment, whether it's a clinoidal or medial sphenoid wing meningiomas. And here the basic question for clinoidal meningiomas was how to approach it in the early stages. So do you do intradural surgery and then see how the optic canal looks like, and then treat the anterior clinoid process extradurally, or resect it intradurally, or do both? So a hybrid approach. And then so there are many different ways to do it, and some surgeons say right away that you should approach extradurally first. So do everything extradurally, do the clinoidectomy, get more space, and then resect the tumor. But you can do it the other way around. So you can decompress the tumor, do intradural surgery, resect the tumor, and then you've got more space, but mostly more bleeding, because you're not treating the origin of the tumor and also the feeding arteries, and then resect the tumor. So in both ways, it's possible to resect the tumor, and but then more consent is in what to do with the cavernous sinus when it is involved. So rarely we really nowadays do a very radical surgery and try to resect tumors which are also involving the cavernous sinus. And so it is quite often the case that you leave it behind for a stereotactic radiosurgery as a remnant. And so one focuses on the clinical outcome and see how also in these cases how the vision does after surgery. So this is just an example of medial sphenoid wing meningioma, which is approached from the paternal approach. Left side, you see the optic nerve, the tumor, the lateral wall of the cavernous sinus, tentorial edge, oculomotor nerve, and also in these cases, I don't think that you really need very extensive approaches in order to see have a better look into the posterior fossa. You just can use the endoscope, look at the oculomotor cistern, and then you see some remnant tumor and resect it by this way too. So, and that's just using the regular serenal approach on the left side. So what can you do when patient has got additional already preoperative some infection of the oculomotor nerve in these tumors? So our strategy, or my strategy, is not to really do cavernous sinus surgery when the tumor is involved in cavernous sinus. However, I made the experience that that it is worthwhile to see whether the tumor is compressing the oculomotor nerve at the porus of the oculomotor nerve, so at the oculomotor cistern, and then you can in these cases it's possible to incise the anterior petroclinodal fold and then decompress the nerve, and there is in many cases there is some significant tumor compression at this area. So like in this anatomical study, you can see the oculomotor cistern, and there in many cases there are tumor infiltration or compression at this area. So it is worth it to do some decompression there without going into the cavernous sinus. Just one example. 58-year-old man, atypical meningioma, has got already ptosis and double vision for 6 months before surgery. And so we did, in this case, on the right side, just a pteryginal approach, and then looked at the oculomotor nerve, which is quite involved at the entry into the cavernous sinus wall, and opened the oculomotor cistern and did decompression there. And sometimes one can observe that the nerve is really has got the discoloration, is reddish, and had some significant compression there. So this is the postoperative MRI where we left tumor remnant at the cavernous sinus. And we analyzed some of them in a small series of patients. We analyzed how they do after surgery, and we saw that there is an improvement rate which can be reached when there is no high grade of paresis before surgery. So it is worth it to do this actually during surgery. Now I come again to the topic. What to do with the cranial process in these meningiomas, anteroclinodal or medial sphenoid ring meningiomas. You know the consensus paper from the ANS and about the surgical management in these cases, and so it is presented that skull-based approach with clinodectomy should be done as a general rule, with the rationale of reducing brain retraction, avoid complications related to large opening of sylvian fissure, and performing an early devascularization of the tumor and early decompression of the involved optic nerve. This is recommended, and I don't know how you do it as a general rule. I must say I do not do it as a general rule. I never did it like this as a general rule, because I think why you need to select what kind of tumor you have actually, or which needs to be operated. In most cases, you can decide. I decide intraoperatively if I do an additional clinodectomy or not. It's really seldom the case that I say myself, I do it right away from the beginning, clinodectomy, and then go inside. But it's a different way, and there are many arguments where one says, oh, it's necessary, you must do it, you should do it in the early stage of surgery because less bleeding, because optic nerve, and so on and so on. One argument is also that in most tumors you see actually an infiltration or involvement of the optic canal. But in my opinion, one can really select and differentiate these kind of tumors, because a lot of tumors just have an intracanalicula tumor compartment which can be resected easily when you use the endoscope intradurally. So you even do not really need a clinodectomy, and you can reach a good visual result after the surgery. So I'm not really convinced that clinodectomy is always necessary to get a good visual outcome. But that's the kind of that is open for discussion. So GTR may not be achieved, and STR is recommended in when atrial wall is involved. Okay, that's I think a lot of people agree with that. And countersinus extension not recommended, and stereotactic radiosurgery for residual tumor. So that's also one thing which has a wide consent among neurosurgeons. Last topic, and then afterwards I would finish my talk. Of course, when we talk about skull-based meningiomas, you cannot miss the petroclival meningiomas, of course. But it's a type of type of skull-based meningioma where you can fill a whole session, and you can really talk along. You need a long time to discuss the approach to petroclival meningiomas. We all know that these meningiomas are very difficult, and we all know that you need to have a lot of experience and do a lot of surgery until you recognize that sometimes maybe you went too far, sometimes you did too much surgery, and so better keep off your hands from special kinds of petroclival meningiomas. However, the problem is you don't know what is the special kind of petroclival meningiomas where you should just leave and do not do surgery. So there are many problems to see it beforehand, before you do surgery. And so of course, the question arises, what is the value if you do radical surgery or try to do GTR in order to reduce the rate of recurrence or progression after surgery? And what is the value, and in which patients should you try to do this, and in which patient it's better to keep your hands off? So there is a consent that the value of GTR in reducing rate of recurrence or progression after surgery, it is demonstrated. So on an oncological point of view, it is clear that radical surgery means less recurrence and also less progression. However, the question is what clinical benefit does the patient actually have when you do this kind of surgery with a very high morbidity or not acceptable morbidity? And recent literature seems to support more conservative strategy in this term, and so do not do radical surgery, more oriented towards preserving the quality of life in the patient, also concerning the cranial nerve deficits. So the extent of resection should be adapted to the intraoperative finding according to the judgment of the expert neurosurgeon. So it's a very general statement where they recommend that you should have an optimum balance between the maximum possible resection while maintaining a good clinical outcome. So, and that's the most difficult thing, of course, because you never know what happens then really after surgery, when you do surgery under neuromonitoring and everything. And so you think, oh, you did a very nice and excellent surgery, and then afterwards the patient does have clinical deficits. And so that is the main problem, and also the main problem is that you cannot anticipate. We analyzed a very small collection of petroclival meningiomas when I was at the medical school in Hanover, with the issue whether there is any way of foresee the difficulty of surgery when you look at the tumor on MRI scans. And well, we didn't find really nothing really special, but we found out that one thing which is generally known in meningiomas, that the tumor margin, of course, when you've got a very nice clean tumor margin, you can anticipate that the tumor will be also friendly to you. So there's no infiltration, and if you've got CSF rim, then it's even better. If you've got arachnoidal cleavage plane, then it's better. And also, when you look at T2 intensity of the tumor, then high T2 intensity means high vascularization, and but a soft tumor, and low intensity means it can be calcified. It can be a very firm and hard tumor. So there is some imagination or any vision of the tumor which you encounter. However, it does not really allow you to see to say whether you should have a fixed strategy to resect one tumor completely, or just do a subtotal, or just a partial resection. So that is still the problem, and I think if you grow older and you've got more experience, and especially in tumors like the petroclival meningiomas, then the surgeon often gets more conservative. So because you learned your lessons, you've seen how difficult some really ugly petroclival meningiomas are, and then you did some of the surgery, you did some of the petroclival, and then you see the real results, and then probably you get more conservative because you know what really can happen after radical surgery. And a young neurosurgeon or a very, very excellent young skull-base surgeon who is eager to have a large experience in that field, he would probably not have really this in mind, and just sees and tries to learn and do his own experience. So that is always the problem in very difficult and very rare and challenging tumors. So finally, what should we do, and what is the when you have an outlook on the development of the treatment of skull-base meningiomas? Of course, there are many paths and ways, and also some vision how it could be in the future. And so there are many medical approaches, immunological approaches, molecular genetic approaches, where we found out that meningiomas are not the same. Even the skull-base meningiomas are genetically not the same. They differ from the location in the midline, or whether they are at the sphenoid wing laterally. They differ from their molecular profile. And of course, it's interesting that we can figure out whether there is any chance of doing medical treatment, and try to find any pathways where you can influence the tumor growth with medical treatment in any sort of agents. And so that's very interesting. We just made a very basic overview, analyzed genetically the mutation profiles in skull-base meningiomas which are associated with mTOR and ERK1/2, and so there are many other extensive publications concerning methylation and the epigenetic changes and things like that. So I think it is very interesting, and for us neurosurgeons, it could be of course a very helpful tool when this kind of targeted therapy could really be applied on patients, very difficult patients, where surgery cannot help at all. Of course, we don't want to get unemployed as a neurosurgeon at one time. So we hope that we've got enough to do and enough to operate. However, it's a very interesting time where we can follow the development, and so hopefully there will be another strategy or a tool to help the patients with very difficult skull-base meningiomas. So thank you very much for listening, and thank you very much also for your invitation. And I'm really happy to answer any questions when there are any. Thank you very much.
Thank you, Professor, for a wonderful lecture. Thank you for sharing your experience and amazing cases. Before I go to the chat part, I have a couple of questions myself. So first of all, like, thank you again. And I was wondering, like, how do you balance the goal of maximal neurosurgical resection of the tumor and the preservation of the neurological functions and the integrity of the cranial nerves? Like, what will be your advice or tips for a young neurosurgeon such as myself?
Yes, I myself think it's very important to see the patient, how old is the patient, what profession has got the patient, and what deficit has got the patient, and life expectancy and the preoperative level of quality of life. Of course, almost every patient want to have surgery, but want to preserve quality of life. There are a few patients who say, "Oh, doctor, please remove everything of the tumor. It doesn't matter how I'm doing after surgery." There's almost no patient who said telling that. Of course, every patient wants to have maximum resection, but preservation of cranial nerves or preservation of neurological function as on the same level, or they can accept when you say temporarily it can get worse, but finally you get like the one you are before surgery. And we need to be honest that it's not the case in every type of skull-base meningioma. We cannot tell in any. The best example is the petroclival. I cannot really tell the patient that, we do the big petroclival and I promise you, you get into surgery and get out of surgery like you were before. So that's just not true. No. And so one thing is just to see, okay, to how to realistically see what is the damage that you can cause after surgery. And is that damage acceptable for a patient who is 70, who is 60, who is 20, or anything? And is that patient, is that the damage acceptable when the patient has got no cranial nerve deficit at all before surgery, or has got some cranial nerve deficit, gets worse and gets better? And then I try to sort out what is really the deficit which can be accepted and where the patient can cope after surgery. So, and that is very, very different from person to person, and also from the profession, what the patient has. So I try to find my way to see, okay, that is the preoperative condition. What's the aim of the postoperative condition? And then you can I try to say myself during surgery, okay, my fingers would like to resect every inch of the tumor because it's exciting and I want to do it, and that's why I do it. But I think it's very good when you're really do a feedback during surgery and say, okay, what was the aim of the patient and what was the wish of the patient and what is the best for the patient? And then sometimes I just stop. This sometimes intuitively because you never know really how many % of tumor is left. But sometimes it's the better way to do. Okay, I leave the rest of 10% in situ and do not try to aggressively resect the tumor. And so that's a more conservative strategy. And I think you go far better with that than to say that I'm really my ambition is to resect everything until I get everything out, and then you're surprised what happens after surgery then. Although a cranial nerve is preserved, or although it looks really nice during surgery. So I think that is one thing which helps when you concentrate on surgery, but at some time during surgery, you just realize what was the really aim of surgery.
Thank you very much for an honest and insightful response. And now I'm gonna ask the question from Dr. Ramazan Özdemir, İzmir, Turkey. What is your strategy if you do not prefer surgery in elderly patients and patients with many comorbidities?
Yes, so in elderly patients who've got many comorbidities, I really I really try to calculate. I see the patient. Let's say the patient, it's a woman who is 82 years old, has got a very big tumor, let's say petroclival tumor, or let's say mid-sized tumor or large tumor, has got no problems at all because the MRI was done, and she's got just a little bit of dizziness or a little bit of headache, which is quite common. And then 81 years, okay, then I try to say myself, okay, how long does an average German woman or European woman live? So it's just a few years, you know. And then is it really 5 to 6 years? Is it better to leave the tumor and just say, okay, try to forget it, forget the tumor, have a nice life? Or you try to make the patient is anxious, and you say, oh, the tumor is very dangerous, you need to do surgery, and otherwise you will die or you'll get complications due to the tumor and things like that. So in these cases, I'm very, very conservative, and so the volume of the tumor does matter, but you need to see the relation to the clinical status. And so when there is some correlation, when there is really an urgent need to do surgery, okay, then sometimes you do surgery. But when there is really no clinical urgent situation, then it's really not necessary to do this kind of challenging surgery.
Thank you very much. Next question from Turkey, Professor Dr. Ayhan Kanat. Cerebral meningiomas occur more often in females than males. What about gender difference of skull-based meningiomas?
Yes, in skull-based meningiomas, it's not 2 to 1, but still the female are more involved, so generally or epidemiologically. That's different, but it does not especially, or it does not limit to skull-based meningiomas, but that's different when you get to high-grade meningiomas. Then you get more males involved, like high-grade grade 3 meningiomas and things like that. Then it's not 2 to 1. It's more males are affected. But in skull-based meningiomas, basically, it's still the predominance of women. Yeah.
Thank you. Next question from Jeremy O. What are your challenges when using Simpson grading to assess extent of resection in the skull-based meningiomas? Do you use other classification systems since Simpson has limitations due to critical neurovascular structures close to the tumor? Interesting question. Thank you.
Yes. So the Simpsons classification, as you know, is very, very old. It's from the 50s, and you're completely right. It's very different from the side of surgery. So classically, Simpson classification is the best when you do, convexity meningioma, where you can excise the dura, and you definitely know, okay, it is resected, and or you leave the dura due to some coagulation and things like that. So that would be the typical case. But you're right, it's not the case at the skull base. But we still try to do this use this classification, but just for a simple reason, because as we began to analyze these tumors, we needed to have a uniform classification, and the uniform classification was the Simpson's classification. So that's why we applied this classification also in our surgical series. And that means that when you have a remnant tumor, which is not at the dura but at the vessel, then of course it's a remnant tumor. It's not a Simpson grade 1 resection. At least it's grade 2 or even 3. One needs to really take care that you do not limit on the dural remnant, and you've got remnants at the nerves or also at the vascular structure. So you need to include this one.
Thank you very much. And we have a comment from Feya. Thank you for your wonderful lecture. And I don't see any questions in the chat, but I have a couple of my questions. I was wondering about CSF leaks as a complications. How often do you encounter and how you do deal with them?
Yeah, that depends on the approach itself. The classic CSF leak with transcranial approach would be, for example, when you do a retromastoid surgery, the CSF leak, which you can get at the mastoid cells, which are quite superficially, and when you do deep surgery in the at the petrous apex, for example, or when you're opening the auditory canal in order to remove vestibular schwannomas, you can also get CSF leak from there, from air cells in the petrous bone. So these are some of the classical ones where you just open air cells somewhere at the petrous bone or mastoid, or when you have a frontal approach, even from the frontal sinus. And the other case would be when you do transcranial surgery, you open ethmoidal cells during olfactory groove meningioma surgery, or you open the ethmoidal cells when you remove tuberculum cellae meningiomas and go more to the skull base, and you can even open, of course, the sphenoid sinus from above. And these are the most often cases where you have to deal with deep CSF fistula. We're not talking about the superficial one, which you can get, in any type of cranial surgery, but at the skull base. And so that means that you just need to be alerted and to know that you are potentially in the position where you can open air cells, and then of course think about it and remember that you need to close air cells everywhere when you open it, because you can get fistulas. A completely different story is, of course, when you do transsphenoidal surgery. And so that's what I mentioned, that you deal every time with the risk of CSF fistula, every time. And so of course, you cover it meticulously with different techniques. But we need to realize that still the rate of CSF fistula is quite high. It's still too high that I personally do not really favor to resect tuberculum cellae meningiomas transnasally, because I think in my hands, the patient is much better when I do it with a minimally invasive transcranial approach.
Thank you very much. And I was also wondering, what is your strategy about the recurrent cases? Do you prefer radiotherapy or secondary surgery? Like, what is your basic approach for the recurrent skull-base meningiomas?
Yes, for the recurrent ones, so I never really do right away radiosurgery or post-operative fractionated radiotherapy, except of grade 3 tumors. So except of grade 3 tumors, and in grade 2 tumors where histology is clear that it's grade 2 and there is a clear remnant seen on the MRI, then I prefer to do right away radiotherapy after surgery. And in all other cases, so grade 1, WHO grade 1 meningiomas at the skull base, when there is a remnant, we first observe and then try to see when is the best point time to decide whether you do any treatment. That can be radiosurgery, of course, or redo surgery. And so that is our strategy, that we first observe these cases, and then of course it depends on where the tumor lies, whether you do radiosurgery or a second microsurgery. Yeah.
Thank you very much. And last question from me, I promise. We live in the era of emerging artificial intelligence, which is transforming the landscape of medical field. And you also mentioned in your lectures involvement in the pre-surgical planning, this technology. How do you incorporate artificial intelligence in your work in a preoperative planning? And do you see it involved in the future, maybe in decision-making process, and how much we reject when we do surgery and so on and so forth?
Yeah, I think we are still quite far away from decision making during surgery using AI. But I think we are on the best way to use AI for preoperative planning. So that means in terms of modeling or pre-modeling of situations where you can anticipate how structures can change during surgery. That's one thing which is very, very interesting to use AI. However, you need to feed the system with tons of data. That's the problem. And so I think that's a very, very interesting way to plan your surgery. Maybe it is sometimes possible to really feed the AI program with radiological data in order to anticipate how the tumor behaves or how the tumor is structured or the characteristics of the tumors. As I said, for example, you want to know how friendly the tumor is at the petroclivar area or somewhere. You've got the problem that with plain and basic radiological data, you cannot really predict. But this is one topic which can be solved using big data and AI. So if you get a lot of input from thousands of petroclival meningiomas with all the the radiological characteristics, then you can use AI to do some prediction. And that's the same with radiomics and all these things where you try to get out histological characteristics from radiological data from gliomas, for example. And so I think that's the way we can really be very, very excited how it works during the next years then.
Thank you very much. Now I want Professor Bektaş to comment, and anyone who is willing from the audience to contribute.
Thank you, Professor, for your excellent presentation. And I thank you for explaining the very difficult topic clearly. Do you still believe meningiomas are benign lesions after so great experience?
Oh, yeah. Thank you very much, Professor Bektaş. Thank you also for your invitation. And for concerning your question, I really do not believe that you can generally say that meningiomas are benign lesions. We all have got series of very, very, very ugly meningiomas, very ugly ones, where we do, I don't know, 4 or 5 times surgery, and it doesn't need to be a high-grade, grade 3 meningioma, but there are so many which are so ugly and so difficult to treat. And finally, all these patients at some time end up with wound healing problems. You've got soft tissue soft tissue problems. They end up with surgery together with plastic surgeons to do a free flap or a pedicle flap in order to treat the wound healing and things like that. So when I see these patients, I do really think that meningiomas can be very, very malignant. Not because the histology is malignant, but because they grow in a very difficult space, and they are very recurrent, and they do clinical problems, although it's not a sudden problem, but it's an increasing problem. So where the patients really, suffer from. And so I think concerning your question, it's not right to tell that meningiomas is a benign tumor, and so it's you are lucky that you have got a meningioma.
Yeah, thank you very much. And with kind permission of Madonna, may I ask another question?
Of course,
Uh,
of course.
What is your advices for our young colleagues for their developing their skills in for surgery, in the skull-based surgery, developing their skills in skull-based surgery?
Learning curve.
Thank you.
Yeah,
Yes.
yeah, learning curve. I think the most important is still anatomy. And I think you as Turkish neurosurgeons, you've got really much more experience and knowledge and training in that compared to, let's say, an average German neurosurgical resident. You know, I think you focus much more on anatomical details. You've got much more societies and meetings and about surgical anatomy and microanatomy, and so that's very. I think it's very important, and I think that is something where we can learn from you, because you put much more importance on microanatomy than we do in a Middle European country. And so I think concerning skull-based surgery, you've got probably a much more detailed training, for your residents. That's just my impression. And also when I see the scientific meetings, anatomical meetings, I think you much more emphasize training in microanatomy than we do.
Thank you very much.
Thank you, Professor Ayşegöz, for your contribution. Kamil Hoca, do you have a question or comment?
No, I have no question. After that wonderful meeting, I want to thank again to Professor Nakamura. Thank you so much. And I want to thank everyone who joined us.
Oh, thank you very much for your invitation. Thank you.
Thank you.
Thank you again for your comments, for your patience and responding to our questions. Thank you for the audience for your contributions. Thank you.
Bye-bye.